One of the things practitioners find hardest to do is develop a system that shifts the country's public health insurance from what you call a voluntary to a compulsory system. First of all, let's look at the term compulsory. Compulsory means that, first of all, the government would have to foot the medical bills for those who cannot manage to foot these bills, the very indigent, as part of the right to health commitment. If you remember the right to health commitment from our previous episodes, we talked about the right of everybody to receive some health benefits or some health services and commodities that without going down into debt. And we found that some poor people could not manage to receive these kinds of services. Why? Because, first of all, um, they might actually be trapped in the cycle or spiral of poverty. Others cannot because they're vulnerable, they've been vulnerable structurally since birth. Some women and pregnant, teen pregnancies, people who are facing teen pregnancies, some of the women might have some trouble accessing these services. So we need to find a way of making sure that all these populations are able to access services. The other form of compulsory contribution comes in terms of mandatory enrollment. Now, a lot of people have developed systems which they call mandatory enrollment. A lot of countries have done so. We know Ghana has developed a system of mandatory enrollment in the National Health Insurance Scheme. Rwanda has developed one. Kenya has recently done so. Basically, the East African community is moving towards such a system. But the big question is, why isn't this system functioning as well as it should? A lot of people say that a lot of studies show that it's not just a matter of coincidence or it's not known. One of the major reasons for this kind of low enrollment, when we say that people must mandatorily sign into health insurance, one of the reasons is because it is simply not enforced. Some governments feel guilty enforcing it. Sometimes people really just don't have the money. Sometimes the government, the political party that promised this kind of mandatory enrollment and health benefits, sometimes you just find that simply the policies of the country change. So a new government is in place and they don't follow through with what the previous administration had put in place. One of the major reasons, one of the embarrassing reasons why nobody will tell you why compulsory or mandatory enrollment fails is because countries simply do not have good enough databases to know who's who. They can know who's employed and who's not, who's paying taxes and who's not. But we know that in Africa, about half or more of the working population, especially in the informal sector, does not really pay taxes. And so there's just no way to trace. There are very few ways to trace them. And if you use the national ID system, there's very little linkage between the national ID system and the real system that you need to measure whether people are accessing health services. So today we are going to speak about something very key. How do you shift successfully from a voluntary to a compulsory system of public health insurance where you can know who contributes and you can actually work towards ensuring that everybody is enrolled? at least 90% of the population, as Rwanda has shown us. So stick with us. We are going to go through the various steps that you need to put in place to ensure that you move from successfully from voluntary to a compulsory national health insurance system.